Пока ждем студентов, но звук уже есть.
Звук есть, да? А я себя могу видеть?
Если хотите, я запущу, да.
Они же меня видят?
Лучше не попадал теперь.
Звук какой отключили?
Все работает. Пока мы разговаривали с вами, я включал.
А, я понял, сейчас включено, да? Все, они меня видят, слышат?
Да, вот уже пишет.
Хорошо. Okay, good afternoon, colleagues. Let's begin our lecture today. Please, who is present? Please in direct write your name and group number. Okay, I see you. Naveen Malik, Sharma, Aprajita, okay. Nice to meet you. Happy to see you here. And let's begin our lecture. The topic of our today's lecture is mechanical or obstructive jaundice. It's difficult and very interesting topic and problem is a surgery. Why? Because jaundice, as you know, it's a complication. It can be like a sign of some infection or diseases like hepatitis B and C or other types, and it can be surgical pathology if it obstructive or mechanical jaundice. As you know, present three types of the jaundice is parenchymatosic, hemolytic, and surgical, mechanical, or obstructive jaundice. What's the definition of jaundice? It's yellow discoloration of skin and mucous membrane. Types, as I told, it's prehepatic, hepatic, and posthepatic. On this picture, you can see anatomy of the hepatobiliary system, and here you can see liver, gallbladder, duodenum, ampulla of Vater, pancreas, and stomach, and localization of these organs. Anatomy. So, on this picture you can see common bile duct, distal part of common bile duct, common hepatic duct, gallbladder and cystic duct, it's here, right and left hepatic ducts. So, what happens in case of obstructive or mechanical jaundice? Happens some problem of the passing, bile passing from the liver or gallbladder to the duodenum. Because, as you know by anatomy, common bile duct enter to the duodenum, and here is a present anatomical structure, papilla fateri. Also, as you can see on this picture, in papilla fateri also enter total pancreatic duct. That's why in some case of problem, common bile duct problem, also can happen acute pancreatitis, like a complication of mechanical jaundice. So, little information about anatomy. Liver, under the liver gallbladder, stomach, pancreas localized behind the stomach, duodenum, ampulla of Vater, and pancreas. This is physiology. On this picture you can see like hepatitis, liver cells. Usually it's forming bile. And by this, from this hepatitis, bile, hepatic duct, forming bile and go to the hepatic duct, then it go to the gallbladder where is it accumulate. And when we using meal and urine feeding, gallbladder doing secretion, and by secretion the part of the bile go to the common bile duct and enter to the duodenum. Bile, main function of the bile is the function of the meal formation in the intestine. So, what is the bilirubin cycle? Usually is several steps. First is the broken down red cells are removed by RAS. Hemoglobin splits into hem and globin. Globin and cell wall protein go down to amino acid. They enter to the amino acid pool. Hem splits into iron and bilirubin. Iron stored as ferritin for rails. Bilirubin is not released, goes to the liver, combined with glucuronic acid to form the conjugated direct bilirubin, water-soluble. Hemoglobin divided to the iron to the ferritin and bilirubin. Ferritin to be released, bilirubin, water insoluble, goes to the liver for conjugation with glucuronic acid to become water soluble. Then it goes to the blood and urine. Plus red blood cells wall protein, amino acid go to the amino acid pool. On this picture you can see normal urine and urine with presence of bilirubin. Presence of bilirubin in urine is called bilirubinuria, and usually it will be dark color. So when you have patient with mechanical jaundice, you every time should confirm urine, what color of this urine. On this picture you can see bilirubin cycle. In these functions includes macrophages of the spleen and bone marrow, and little pathophysiology is a hem bilirubin, it goes to the bilirubin conjugated. All this forming in liver processes is hold there, and then by this bile forming bile, and bile go to the gallbladder, and as I told, to the duodenum. Here you can see patient classic, as I think, patient with mechanical jaundice. Usually these patients with icterus of eyes. Usually you will see these patients icterus of the skin. Yellow color skin, yellow color eyes. But this patient is with high level of bilirubinemia, high level of the bilirubin in the blood. Sometimes it's not so classic, eyes not so yellow and skin not so like here. But you can check it by, as you know, blood count. You can check it by bilirubin level. Causes, and what are the causes of obstructive or mechanical jaundice? First of all, of course, it's stones. What stones? Which stones? It can be stones from gallbladder, as usually happens. Stones from gallbladder go to the common bile duct and block it, and then, as a result, begins mechanical jaundice. Sometimes stones can be formed in common bile duct. For example, we have sometimes for patients which we operated 2-3 years ago with bile stone disease in gallbladder. We performed cholecystectomy, removing of gallbladder with the stones. And after 1, 2, 3 years, patient come back to us and tells that he has some pain in epigastric area. We're doing investigation, of course, and the main and best from it is MRI. MRI cholangiopancreatography or ultrasound, but MRI, of course, is better. And we performed MRI and find stones in common bile duct. So patient having gallbladder where usually accumulate these stones, but these stones can accumulate and form new stones in common bile duct. So cases can be also. So main cause of mechanical jaundice, of course, it's stones. Second cause is strictures. Strictures can caused by any benign problems or some malignant problems. But usually strictures can be simple. Not compression, not by compression, just stricture of common bile duct or stricture of papilla artery. And as a result, of course, mechanical jaundice. Third cause is cancer of the head of pancreas. In this case, forms tumor in the head of pancreas and it's growing, and as a result happens compression of the pancreas, of the head of pancreas to the common bile duct or to the hepatic duct or compression of liver. And in this case also can happen mechanical jaundice. 4 is a cholangiocarcinoma, is a malignant disease, malignant tumor of the bile ducts. When tumor forming and growing inside of common bile duct. 5 is a periampullary tumor of the ampulla of artery. Of course, this usually can be benign also and malignant. 6 is a pressure from outside. Any pressure, lymph nodes, something else, some process, maybe some benign process, or maybe some, for example, hepatitis and increasing sizes of the liver or something else. 7. Colorectal cysts. Sometimes benign cysts can grow inside of the common bile duct, and it's also block common bile duct and give mechanical jaundice. And parasites. Parasites which usually localized in the intestine, usually it's large intestine, sometimes small intestine. Sometimes these parasites can go to the duodenum, from there enter to the papilla artery and common bile duct and block it. Also can be like a cause of the mechanical jaundice. Causes in the lumen is ascaris, coronariasis, parasites, and hydates, rhabdomatosis, cholangiocarcinoma, stones is the commonest, of course. Strictures. Here you can see benign strictures, how it's look, and malignant strictures. Outside the wall causes. It can be any masses from outside. It can be stones in the cystic duct. Yes, it's also interesting. This is called Miller-Z syndrome, which localizate in Hartmann pouch and then give Miller-Z syndrome, I tell you now. And head of the pancreas, compression by the head of the pancreas. About Miller-Z syndrome and about stones in cystic duct, sometimes these stones which localizate in gallbladder and in the neck, especially in the neck or Hartmann's pouch localizate stones, sometimes these stones without entering into the common bile duct also can give mechanical jaundice. How? For example, this stone, which localized in the Hartmann's pouch, it's compressed, it's localized there and compressed common bile duct with inflammation process, of course. If it will be without inflammation, mechanical jaundice usually will be absent. But if here localized stone and patient also have inflammation, acute inflammation of the gallbladder, usually here this This stone can compress common bile duct, and it also can be cause of mechanical jaundice. And little stones, which can enter to the cystic duct and then go to the common bile duct, and they are blocked. And here on this picture you can also see Mirzi syndrome, when stone is fixated in the neck of the gallbladder. Here you can see the standard common hepatic duct, inflammation causing obstruction, what about I told, impacted gallstone in cystic duct, and the standard gallbladder. So inflammation causing obstruction is called Mirzi syndrome. Benign strictures. From the benign causes, it can be biliary atresia, it can be iatrogenic. Iatrogenic, it means, for example, biliary surgery, after biliary surgery on biliary ducts, gastrectomy, hepatic resection, liver transplant. Sometimes during very difficult surgeries, difficult operations, in case of inflammation, acute inflammation usually, of the gallbladder, can be unfortunately some iatrogenic problems. For example, trauma of the hepatic duct, ligature of the hepatic or common bile duct, and after operations, in patient begin mechanical jaundice. So first of all, what about we should think that we don't do something incorrect, and we exactly should do investigation, confirmation of this problem, and manage it. Third cause of the benign strictures is usually inflammatory problems like pancreatitis, sclerotic process of the common bile duct, and cholangitis. Cholangitis is the acute inflammation of common bile duct. Cholangitis can be due to trauma, idiopathic, and radiotherapy after radiotherapy. On this picture, you can see how will look biliary atresia. So you can see bile ducts here, it's not normal, because usually diameter of common bile duct and hepatic ducts usually it's about 4 till 6 millimeters. Usually. Here you can see it's like a track. And here it's also. So it's atresia. Total blocking of the biliary duct. Of course, bile can go out from the liver to the duodenum. Here you can see different types of the blockade of the common bile duct. This one, it's obstruction from outside by any tumor process. You can see how it looks. Common bile duct compressed from outside by tumor process. This type, it's when cancer process localized inside of the common bile duct. Next one is the presence of the stone inside of common bile duct with inflammation around. Inflammation also can give mechanical jaundice, but inflammation it's secondary problem, it's secondary disease. Inflammation every time begins from some cause. Here it's stone. Also, one from all causes of mechanical jaundice. For example, if you, on this picture, if you see total blockage of common bile duct by stone and inflammation around, here you can see stone, but without inflammation, and you can see that here it's not total blockage. So some part of bile can go outside, go out to the duodenum, but stone is present. What can be in this type by clinical picture? In this type by clinical picture, in patients cannot be any mechanical jaundice. For example, patient can complain to sometimes epigastric pain or sometimes presence of the jaundice, but not every time, or without any jaundice, but presence of the pain, or sometimes without pain and without jaundice, and we cannot know about this anything before patient will feel someone complaint from every or pain or jaundice. So in these cases, patients, it's more difficult to diagnose. First of all, diagnose when patient haven't any complaints. But usually here can be or not be not present mechanical jaundice and pain. It can be or absent. Next type, inflammation or growing inside of the common bile duct. Here you can see gallbladder, cystic duct with a stone, common bile duct, right and left hepatic duct. And here you can see fixed stone in the cystic duct. Usually, this problem, it cannot give any mechanical jaundice. Why? Because stone is fixated in the neck of the gallbladder, in the cystic duct, and it don't go to the common bile duct. That's why, usually, if this stone don't move in future to the common bile duct, we can finish this problem just with cholecystectomy, and that's all. In that case, when there are no any complications, no any moving of the stone or no any forming of the Mirzi syndrome. Next type, inflammation of the gallbladder. No any stones in gallbladder. Stone is go to the common bile duct and fix there, fixation with obstruction. This type is you can see like stone from cystic duct go to the common bile duct, and by fixation of in the cystic duct, it's blocked common bile duct. Of course, will be mechanical jaundice. So this is different types of the mechanical jaundice by the stones. And on this picture you can see multiple stones in opened gallbladder after cholecystectomy, and you can see what are the different stones patient have: big, small, different forms, different structure. Of course, little stones is more dangerous for the mechanical jaundice. Why? Because big stones can go to the common bile duct. Usually, it's fixated in the neck of the gallbladder. Small stones can go and block there. Impacted stones at the lower end of the common bile duct also can be as a cause of mechanical jaundice, and usually it's fixated here. Ascending cholangitis with liver abscesses also can be cause of mechanical jaundice, and any abscess formation also can be a cause of mechanical jaundice. No any difference which organ abscess. It can be organ abscess, it can be between bowels abscess, it can be abscess of the liver, it can be any cysts, simple echinococcus cyst. If it localized in the area of the bile ducts, it can compress, of course, it and block. On this picture you can see cancer of the head of pancreas, removed cancer, and you see you remove pancreas, and you see head, body and thigh of the pancreas, and what abnormal sizes of the head of pancreas. Head of pancreas with tumor process. Here you can see endoscopic view of periampullary tumor. Usually to diagnose presence of the stones in common bile duct, usually we use duodenoscope. And usually procedure which we using is not only MRI, cholangiopancreatography, we also use endoscopic procedures. One from it's duodenoscopy, and by duodenoscopy we find papilla fataria. On this picture you can see abnormal growing of the periampullary area of the duodenum. And here is periampullary tumor. How we can know benign or malignant? Of course, take biopsy with results. Here you can see cholangiocarcinoma. Bile accumulates, often leading to jaundice. Tumor blocks flow of bile in intestine. And cholangiocarcinoma sometimes also can be cause of mechanical jaundice. Here you can see removed cholangiocarcinoma after operation. Microview. What the procedure is it? It's MRI cholangiopancreatography. Common bile duct stricture here you can see. And this is stricture. This is the area of stricture. This is duodenum, common bile duct. Of course, it's abnormal dilation of common bile duct by the pressure because it's not normal. It's very dilate, I think about 3 centimeters in diameter. And here is block. If it's stone, usually we see this stone, shadow of the stone in the area of the blockage. And here you can see gallbladder, stones in the gallbladder, and also blockage here. Sclerosing cholangitis, associated with usually colitis in 70% of the cases, may lead to malignancy, unknown etiology, symptoms of cholangitis will be present, and treatment of this condition is antibiotic therapy, or surgical treatment is liver transplant. Symptoms: pain, yellow discoloration of the skin, dark urine, clay-covered stool, itching, fever if cholangitis is severe, loss of appetite, loss of weight in malignancy. Signs: loss of weight in case of malignancy, toxic in cholangitis, intoxication of organism, yellow discoloration of the skin of the eyes, Schreiser signs, Virchow notes, tender IUQ in cholangitis, Courvoisier law in case of cancer of the pancreas, abdominal masses palpation, sometimes we can feel, and ascites in case of malignancy. Usually, ascites is a result of any malignant process in abdominal cavity. So, if you see patient with presence of ascites, first of all, what about you should think? It's any tumor in abdominal cavity, or second, it's portal hypertension. Portal hypertension can be due to some angio problems or hepatitis. Also, you can see a patient with deep jaundice, and here you can see a point where usually we palpate lymph nodes, and this is Virchow sign, Virchow nodes or Troiser sign. It's increased in sizes, regional underclavicular lymph nodes. Courvoisier law. The standard gallbladder In case of cancer of the head of pancreas, usually can be also positive. What is it? It's palpation, it's feeling under your fingers, urine palpation, some mass. It can be in right part under the ribs or right hypochondrial part, and usually it's forming from some masses. This mass can be gallbladder, hypertensional gallbladder, or it can be like some mass tumor or some organ. Here you can see ascites in advanced cancer process head of the pancreas. You can see ascites very increased in sizes abdomen with umbilical hernia. You can see like umbilical, it's dilate in increasing sizes. Patient have very big hypertension in abdominal cavity due to ascites. What we can do in this case? Of course, we can do puncture, synthesis. Yes, peritoneal synthesis. We can do evacuate fluid, ascitic fluid, and give this fluid to the lab test to see any atypical cells inside. It's first what we can do to compensate condition of the patient and investigate this patient to any cancer process or portal hypertension. But here it's of course cancer of the head of pancreas. What the investigations we will use? It common blood count, it's prothrombin, MLS of course, electrolysis, urea analysis, and other things. But main from investigation, every time we use blood count with bilirubin levels checking. Why it's important? Because we confirm by these tests, we can confirm increased level of bilirubin. Normal levels of bilirubin is usually 6.5 to 20.5 till 20.5 in these areas. Also, you may know that bilirubin divided to direct and indirect, or conjugated and unconjugated. Usually normal proportions of the direct and indirect bilirubin, it's 75 to 25. So unconjugated, indirect 75%, conjugated or direct 25. Why it's important? Because during any changes of these levels, usually it's tell you about that or another problem. Usually normal or changing of the proportions of the bilirubin can tell you about hemolytic or parahematosic or mechanical jaundice. Different changes, different pathologies. Of course, we use ultrasound. By ultrasound, we can find stones in gallbladder. Sometimes we can find stones in common bile duct, but not usually. Why? Because in the area of the localizing of common bile duct, usually localize duodenum and intestine. And due to that, duodenum and intestine usually have air. Due to this, ultrasound is not exactly procedure to confirmation of the stone's presence. 50 to 50. Exactly procedure is MRI cholangiopancreatography. By ultrasound, we can see stones in common bile duct. Sometimes we can see stones in gallbladder, and here by ultrasound we can see it. It's successful. Yes, you can see duct. This duct is dilated, and this is presence of the stones. Also, we can use CT, double barrel sign, descendant. You can see on this picture, but better will be, of course, MRI. And one of the best procedure, as I think, is ERCP. What is it, ERCP? ERCP is endoscopic retrograde cholangiopancreatography. Usually we do this procedure after MRI cholangography. Why? Because by MRI cholangography, first we confirm presence of the problem in common bile duct, stones, cancer process with compression on restriction on something else. After that we confirm. Next procedure which we will use is ERCP. This procedure is very interesting. Why? Because it's combined. It's twice combined. Because first, it's combined by procedures, by methods, is endoscopical and X-ray procedure combined. And also, second, in which this procedure is combined, this procedure is for diagnostic and for treatment too. So in this picture you can see how doctor, physician enter endoscope. It's duodenoscope. Through this duodenoscope, by working channel, we enter catheter, special catheter to the papilla of artery. This is papilla of artery, where enter common bile duct to the duodenum. So we enter duodenoscope, we find papilla of artery. Through working channel, we enter catheter to the papilla of artery and then enter contrast. After we enter contrast, we switch on X-ray, and on X-ray we see presence of any stones inside of the common bile duct. After that, so we perform diagnostical part of this procedure. After that, we remove this catheter with the contrast, remove, and enter here special equipment. It's called Dormer basket. So if we find stones, we enter Dormer basket. Due to this Dormer basket, we try to remove these stones outside, and it's look so. This is Dormer basket, this is duodenoscope. This is Dormer basket, this is remove stone. Usually, we don't remove this stone outside. Usually, we remove it to the duodenum and put there. And by masses, feces, it go outside. That's why it's nice procedure, diagnostical and treatment. Also, we can use some balloon catheters to the removing of the stones. Special catheters with a balloon on the end. We enter these catheters to the common bile duct, open balloon, and try to remove stones. But Dormer basket, of course, is better. Here you can see RCP, common bile duct stones. You can see very dilated in sizes, common bile duct. Right, left hepatic duct, common bile duct, and here very big stones, maybe 2 stones. Blockage zone. This is duodenum. Same problem, dilated common bile duct and stones. 1, 2, 3, 4, 5, 6 stones. Also, by ERCP, we can do stenting. For example, if we perform MRI, if we perform ERCP, and we confirm that cause of mechanical jaundice is not stones, it's some stricture or it's compression from outside by tumor process, we can do stenting. Stenting of the Z problem area of the common bile duct. What is a stent? Special equipment, tubular form, special equipment which can open and decompress that area which is compressed. Usually we enter stent by ERCP Yes, same procedure by ERCP, by duodenoscope. We enter special catheter. This is it, special catheter, which have inside stent. And we enter to the common bile duct, switch on X-ray, by X-ray control and by eye control by endoscope. We enter the stent inside of the common bile duct, then switch on X-ray, and on X-ray we see the stent. It's X-ray positive. We see the problematic area, open the stent in this area, and leave there. That's all. Stent is opening and do decompression of the bile duct. We treat our stricture or compression. Of course, for sometimes quality of the life quality of the patients will be very good. But of course, it's palliative procedure. It's not radical, of course. It's palliative, it's timely for some time, because if tumor will grow in future, of course, compression can recur, of course. But for sometimes, patient life quality will be better. Here you can see stone removed. Also, common bile duct, dilated common bile duct, duodenum, papilla forteri. On this picture, you can see common bile duct stricture. You can see dilated common bile duct, and here we don't see anything. Some stricture is present here. Common bile duct stent with good flow. On this picture, MRI, you can see. No, sorry, it's not MRI, it's the X-ray during ERCP. And you can see common bile duct. And this is what you see, it's stent. This is whole stent which open, which working. And we compensate flow of the bile. Cholangiocarcinoma. Also cholangiocarcinoma. And here also ERCP we can use for extrahepatic cholangiocarcinoma, and not only cholangiocarcinoma, for any tumor process, no any different, liver, cancer, pancreas, cancer, something else, not tumor. For any compression from outside, we can use stent applying to the common bile duct, and it will give very nice effect. It's minimally invasive, it's without operation, it's very good. One more periampullary tumor endoscopic view. And here MRCP, MRI cholangiopancreatography. What is it, PTC? Percutaneous transhepatic cholangiogram. Sometimes when we have a possibility to do ERCP, or for example MRI, MRCP, we can do percutaneous transhepatic cholangiogram. How we can do it? We can do it by ultrasound control, ultrasound guideless. We find some bile of the liver, doing by ultrasound control punctures there, transhepatic puncture, transcutaneously. Doing puncture, we see bile, how through our needle going bile, so we exactly there. Then we enter contrast inside of the puncture needle and doing X-ray. So we're doing antigradic cholangiogram, and we can see also problems inside. This is peroperative cholangiogram, and you can see how it's good. Look, all bile tree. common bile duct, right-left hepatic ducts, or little hepatic ducts you can see. If we're doing transcutaneous, transliver cholangiogram, we usually enter from this side through the skin. We enter to the one of these little bile duct and contrasting of all bile tree. After that, we're doing X-ray and see same picture. On this X-ray, you can see T-tube cholangiogram. What is it, T-tube? Sometimes we're doing some drainages of the bile ducts. For what we're doing it? We can do it for treatment. We can do it to patient's life quality increasing. We can do it to mean it's to decompression of bile ducts. Because if patient long time living with bilirubinemia and mechanical jaundice have very increased levels of bilirubin, these patients will have compression and hypertension in bile ducts. And in this case, we can do drainaging on the bile ducts. But this T-tube cholangiogram, usually T-tube we enter after operation. During operation we enter and put T-tube, leave in postoperative period to decompress for sometimes maybe 5, 6, 1 week, 10 days to decompress bile ducts. And also we can apply T-tube when we performed intraoperational cholecystectomy, removing of the stones during operation, without RCP during open or laparoscopic operation. And when we're doing cholecystectomy, cholecystectomy is incision on the common bile duct for the removing of the bile stones. If we did it, we can apply T-tube, first of all, to prevent any accumulation of the bile inside, in that area. Second, it's to the better suturing of the common bile duct and to prevent any postoperative strictures of the common bile duct. Sometimes drainaging of the common bile duct we can do also before operation, but usually it will be percutaneous ultrasound guideless puncture of the hepatic duct to decompress bile ducts, to decrease bilirubin in the blood. Why? Because very high level of the bilirubin in the blood, it's a very toxic process to the human, to the organism, and it can give often complications after operation and during operation. That's why if the level of bilirubin is very increased, we can apply tube in some bile duct, no any different which duct it will be, hepatic duct, common bile duct, to decompress this hypertension and to decrease bilirubin. Because high bilirubin in the blood will give during operation bleeding. First, it's very bad coagulation function of the blood. Will be bleeding. It's risks in postoperative care and period for any inflammation process, purulence process, and other things. Insufficiency of the sutures and other. That's why if the level very high of bilirubin, we're doing preoperative decompression of the bile ducts. This is drain cholangiogram. You can see here we drain bile ducts, and to contrast we found some X-ray pictures. So what is the management? Of course, it's correction of the deranged parameters, administration of vitamin K, antibiotics to prevent any formation of cholangitis and to prevention any forming of complications. Monitor pre, intra, and postoperatively to prevent hepatorenal shutdown. In case of high levels of bilirubin, it sometimes can be hepatorenal shutdown insufficiency. That's why we try to compensate all organisms and systems during this condition. Surgical procedures. It's of course stone sphincterotomy. We're doing sphincterotomy or papillotomy of papilla artery and remove stones, of course. Remove stones from common bile duct is a cause of mechanical jaundice. Stones, we remove it and problem is over. Stones exploration of the common bile duct. In case of stricture, we can do resection anastomosis for short strictures, but before it, of course, we use a stent. If applying of the stent is impossible, just in this case, we're doing resection anastomosis. We can resect this part of the stricture and apply new, or we can do any shunting operations. So we apply anastomosis between common bile duct and duodenum, or common bile duct and jejunum. Choledoca duodenal or choledoca jejunal anastomosis. So shunting operations in common bile duct. For strictures, stenting, short and long. In case of cancer process of the head of pancreas, we can do several operations. If it's radical operations and early step of this problem, we can do big operation. Radical is Whipple operations or pancreatic duodenal resection. What is it? Pancreatic duodenal resection is a resection of the head of pancreas. It's cholecystectomy. It's resection of the part of stomach. It's a resection of the part of common bile duct and applying anastomosis. So it's very big radical operation for cancer of the head of pancreas. Of course, it's a very traumatic operation, but if we find this cancer process in early steps, yes, and stage is not more than 1, we can do this operation. And late is bypass surgery. What about I tell? It's cholecystojejunostomy, choledoca duodenal, cholecystoduodenostomies. Any forms of stomy anastomosis between common bile duct or gallbladder with duodenum or jejunum. Here you can see stand for cancer of the head of pancreas. How it's look, duodenoscope, stand, through duodenoscope endoscope we enter stand and apply it to the common bile duct, that area which compressed from outside. On this picture you can see Whipple's operation. All steps of Whipple's operation: pancreatic duodenectomy, gallbladder remove. We remove part of the duodenum. We remove part of the head of pancreas with papilla artery. And then what we're doing? We're doing duodenum pancreatic anastomosis. So we apply anastomosis between duodenum and pancreas, safe part of the pancreas. We're doing choledoca jejunostomy, and we're doing anastomosis between stomach and jejunum, like a biliary. This is Whipple's operation. Very big operation. And here you can see what we do. One more. Anastomosis between stomach and jejunum, duodenal pancreatic anastomosis, and choledoco jejunal anastomosis. So, bile, after this operation, will go directly from the common bile duct to the jejunum. Pancreatic juice will go directly to the duodenum. Here is bile, enter, and here it's meal from the stomach. Thank you very much. It was mechanical jaundice lecture, and if you have any questions, please ask. I will be happy to answer you. Thank you too. Maybe you have any questions? Okay, if no any questions, I wish you success. Of course, take care in this very difficult period of COVID infections. Take care and everything will be okay. Bye bye.